Okay, so going over general anxiety disorders, um, something to kind of keep note on in terms of your neurotransmitters and why the meds that we're using are the meds that we're using. Um, some of the neurotransmitters that are thought to be out of whack are your norepinephrine is considered to be increased. And going all the way back to other pharmacology courses, going back to last week, pretty much every week we've been talking about neurotransmitters. Norepinephrine is it's the one that's going to be controlling your fight or flight response. So this is going to contribute to higher heart rate, higher blood pressure, both of which can be attributed to uh, increased respirations, that kind of stuff. It can be attributed to anxiety and increased norepinephrine. Serotonin's your smiley serotonin. So in people with anxiety disorders, this is going to be thought to be low, meaning you're going to have less mood and anxiety regulation, as well as GABA. GABA is the inhibitory neurotransmitter. So if it's thought to be low, that means there's less of a inhibition or calming effect. So all of that correlates with anxiety. I did write down like the different levels of anxiety. You don't have to memorize the very specifics of it, but you can kind of just use it to look at the trend. So anxiety, when it's mild, is actually supposed to be beneficial, and it's there in order to kind of as you could say, it's like kind of to keep you from being lazy and just kind of get you alert and focused on one thing. When that anxiety increases, it leads to things such as decreased attention span or selective inattention. So you're focusing on the thing you're anxious about and ignoring some of the things around you, which comes with its own set of demerits. Um, but you're still able to follow directions with assistance. So for a lot of people, you guys are in nursing school, so a lot of you guys are probably hovering around here on average. And then some people will potentially be here depending on how the day goes. But for most people, this is where they're at. For situations of really high anxiety, it can get to severe to even like complete panic. So when it becomes severe, you're going to be very much hyper focused on something immediate. You're going to start having physical symptoms. So increased heart rate, dilated pupils, tachypnea, palpitations, a headache. All of these are thought of to be, the SNS response, the fight or flight response. And this is where there's really the start of having like a really big physical and mental demerit and becomes like a genuine problem. Someone that goes even further past that is going into complete panic, in which case they lose control per se, and that comes with dissociation. So meaning that they're not really like if you talk to them, look at them, it's like they're out of it. They're just out of it. They're too focused on the thing they're anxious about, or maybe they don't have anything specifically to be anxious about, but they're just out of it. Someone that has a generalized anxiety just might just get anxious or have panic attacks, can just get anxious over potentially nothing happening. Just their body decides it's time to get anxious. They can be impulsive, have a hard time communicating, have extreme fear, and this is when it really opens them up to getting into car accidents, walking into traffic unknowingly because they're not paying attention. Just general inability to recognize danger because they're so hyper focused on something or just hyper focused on the feelings of anxiety. So some types of anxiety disorders include obsessive compulsive disorder, so OCD. This is defined by obsessions and compulsions, and they have to be strong enough to impair your daily functioning. The difference between an obsession and a compulsion I have written down here. So obsessions are like intrusive thoughts and urges, while com the compulsions is essentially the acts done in response to the obsessions, whatever repetitive behavior. So, for example, washing your hands all the time, checking your locks, checking that your door is closed, checking that your lights have been turned off and off in your kitchen, reordering things. And like I said, this is to the level where it's impairing day-to-day functioning and causing genuine distress. And some of the things that you want to consider with OCD for your NCLEX and then also for your Kaplan exams is that you do not want to abruptly stop or disrupt any of their rituals early on because that could cause them to have a panic attack, cause them to have their anxiety just escalate to the point of needing more hardcore de-escalation. But what you're supposed to do is that you're supposed to gradually set limits and encouraging alternatives over time, but not like immediately right away. So kind of think of it like tapering down a medication, or think of it like, or just like someone taking a medication. You don't want them to abruptly stop taking them because that could lead to like a rebound effect. So you slowly over time wean them off. And in terms of treatment, that's going to be one of the things that would be like one of your answer choices. Um, Cognitive behavioral therapy with exposure and response prevention, ERP, is the is the exposure to the obsession and the prevention of the compulsive response. So it is essentially exposing them to whatever it is that is going to cause them to feel the urge to act and then intervening the compulsion itself. Over time, the idea is that this is going to make it easier for them to cope with their triggers and not fall back into that ritualistic response. And this is the first line. Therapy is going to be your first line for OCD, but there are also medications that can be given. And generally, SSRIs are going to be the first line for medications. Let me see. I don't expect you guys to be tested on the medications specifically, but I do expect that you will have a question in regards to um, asking you whether, either directly or indirectly, asking you whether you should stop their rituals or like how you should handle their behaviors, and expect to have like a question in regards to like treatment is going to be primarily focused on therapy. Um, Additionally, the structured limit setting, kind of like I mentioned, gradually set limits and avoid. Another thing is to avoid reinforcing the compulsions excessively. So kind of goes together here, where you don't want to abruptly stop it, but you also don't want to just let them keep doing it over and over again over that long period of time. At some point, you do have to set the boundary um, in order to kind of help with the behaviors. Generalized anxiety disorder. This is excessive anxiety or worry occurring more often than not for at least 6 months. So kind of going all the way back to here, somebody with healthy anxiety is usually here, maybe here. Somebody with generalized anxiety disorder is likely here as their baseline and can often get to here. Or if they have panic attacks, get all the way up to here. So normal person hovers around, this is going to be their baseline, or zero anxiety is going to be their baseline. And they can get here or here, depending on the situation. Someone with generalized anxiety disorder is going to start out in that um, mild to moderate is going to be their baseline, and they can ramp up depending on the situation. The treatment for generalized anxiety disorder includes these medications here that I'll go into more detail down there in a bit. But your first line is going to be SSRIs, and I did go over SSRIs in either week 1 or 2. So for specifics on that, the outlines on those weeks have some of the hyper specific stuff on the SSRIs because they are also primarily used as antidepressants. but it is the first line for long-term treatment. The medication that I'll go over in more detail down below is buspirone. This one's specifically approved for generalized anxiety disorder, and it is preferred over benzodiazepines for long-term management because it's not addictive and just has a generally lower side effect profile. Other medications that work that are also covered in either week 1 or 2, SNRIs, Effexor and Cymbalta have been approved for generalized anxiety disorder and a few other conditions. They're still primarily antidepressants, but they do have a use case for social anxiety and or um, generalized anxiety, as well as Cymbalta having some of the benefits of helping with pain. Benzodiazepines that I'll also go over because one of your prototype drugs that to focus on is Ativan. They can be used short term. Typically, the ones you'll see, I guess you could see Ativan too, technically, for like agitation, but Xanax and Klonopin are going to be your most common ones that you'll see for benzos in terms of anxiety. So Xanax is going to be there for panic attacks, like a quick and short lasting effect. Klonopin is going to be more as a routine medication for anxiety that is not being properly managed with SSRIs, but it is not meant to be a long-term thing because they are addicting and can be difficult to taper off. And then also Ativan can be given for like very, very acute agitation. Okay, but more details down below. Panic disorder. Panic disorder is someone that's having panic attacks, and it's going to come with all these physical symptoms here. So this is kind of just the disorder of getting randomly out of nowhere being put into a complete state of panic, dissociating, having impulsive behavior, having physical symptoms. Um, I guess I'll also mention um, right here. So more of this stuff again. So I'll just repeat that here. So it's just more clear. Okay. And people with panic attacks, like we mentioned, are at higher risk of impulsive behavior, higher risk of being taken out of reality, which increases the risk of suicide, either accidentally or purposefully. Treatment is still going to involve therapy, but it's also going to involve SSRIs. So all of these anxiety disorders are being managed by SSRIs in the medication side. Here is more like a fun fact. You don't have to know this. I'm gonna make it blue. It's like extra info for people that are interested in psych. These are the SSRIs that have the highest evidence for panic attacks. And something that I talked about in the previous weeks with the SSRIs is that they cause activation. Activation referring to nervousness and jitteriness. So it's and each meta is more likely than others to cause it or less likely. But people with panic attacks are extra sensitive to that. It could exacerbate a panic attack initially, so they'll just be titrated more slowly compared to people with generalized anxiety disorder. And people with panic disorder or panic attacks are more likely to also have a benzodiazepine such as Xanax for the acute or short term, because that's just how severe they present. And then the last one I'll go over before going over phobias and then leading to meds, PTSD, post-traumatic stress disorder. This is something that develops after somebody experiences or witnesses a traumatic event. It can include things such as war veterans, people that have been physically, sexually abused, um, emotionally abused. So all of that could lead to PTSD, and there's technically something called complex PTSD as well that you don't really have to focus on. But the CPTSD, complex PTSD, meaning that they have it's not just one cause that leads to the PTSD, it's multiple causes that leads to their PTSD. But this one's usually portrayed a lot in media, so it might be familiar because you've seen it on TV or movies, but it comes with flashbacks, nightmares, avoidance of situations. So these people might, if they were sexually abused, might want to avoid men, might not want to be around men or people that look like their abuser or people that behave like their abuser. They might have sudden changes in their mood or thought process because they're essentially going through flashback episodes or their brain is essentially kind of giving them that signal of danger, kind of digging back into whatever caused their trauma. So it might cause them to suddenly flip in response as a defense mechanism. And another symptom is called hyperarousal, not to be confused with hypersexuality. Hyperarousal referring to being hypervigilant, meaning that they're on a high sense of alertness and are easily startled. So somebody, maybe like a patient in their room, you might knock in their room and then open the door and they might get startled, because they're just hypervigilant to everything. Every little thing causes them to suddenly kind of flip as a defense mechanism, um, to being put in a traumatic situation. As per all these other anxiety disorders, the number one treatment is going to be therapy, uh, cognitive behavioral therapy, and SSRIs. And like I said, you don't have to memorize. Sure. Yeah. So SNRIs. So going back to the neurotransmitters, the norepinephrine is increased, which could lead to they're not contraindicated per se, but you just have to be considerate with them. So with people that have anxiety, SNRIs are going to cause initial increase in anxiety, which can be, not optimal, but over periods of time, these medications will stabilize in the body and those feelings will go away. But due to that, um, it is not the first line over SSRIs. Even though sometimes the SNRIs a might have like a better side effect profile. Just because with people with anxiety, it does not it has that risk of, well, not risk, it's gonna happen that you're gonna have worse anxiety in the beginning, but it's gonna stabilize out towards the end. So I have like a little quirk about it somewhere over here. So for SNRIs, um, can be counterproductive in the immediate short term because it can lead to increased anxiety, but the body will adjust in the long term. So, for example, these two medications ha are and have been given for anxiety. They're FDA approved for anxiety. They can be effective for anxiety. It's just kind of that um, instance where SSRIs are not effective, or for whatever reason they might need this to be handled as well, like either low energy or concentration, or they have pain, where you might want to consider this. But it is not strictly counter indicated. It's just something to be cautious of that it's going to make the anxiety worse initially until the body gets used to it. So you kind of have to use your best judgment. Like if somebody is having panic attacks, like somebody has a panic disorder, even with SSRIs, you're actually lower dosing them and titrating more slowly because of that. So somebody with a panic disorder is probably not gonna be wanting to be put on an SNRI because that could definitely trigger more panic attacks. But somebody with a more um, typical or more mild to moderate generalized anxiety disorder, that SNRI can make them more jittery, more activated, but it will in the long term, the body will get used to it and it'll be fine overall. But someone with really severe anxiety, panic attacks, yes, that then in that scenario it will be not recommended because even SSRIs are being given with caution at a low dose and slowly increased at a slower pace. Okay, good question though. Um, Okie dokie. And again, these don't have to memorize this, but it's there for your information. Let's see. Typically, the starting ones are going to be for SSRIs are going to be Lexapro, escitalopram, and sertraline Zoloft. As you can see here from GAD, from um, panic attack, and from PTSD, Zoloft is used a lot. Zoloft and Lexapro are like your two typical starting ones. Just have the best side effect profiles and evidence for. And some of the other ones are only really if the situation calls for it or the starting ones don't work well, so they try a different SSRI. And if that doesn't work, they might go to an SNRI or a different class of medications altogether if needed. But one of your important patient educations with your medications is going to be that all like 90% of your psych meds are going to be, especially the routine ones, are going to be a slow and it's going to be a slow process. It's going to take 2 to 4 weeks for some meds, even 4 to 6 weeks before some of those the peak beneficial effects happen. So medication adherence is going to be your number one thing that you'll be asked on in test and in NCLEX and Kaplan. So that's something to keep in mind always. Any questions on anything else so far? Awesome, awesome. Um, some of the phobias that Carrie goes over include these. The ones that I believe gets tested on specifically is going to be your agoraphobia. It's one of the most common phobias, is just the fear of you could think of it like a fear of crowds, but more specifically, it's the fear of situations where help or help is unavailable or escaping might be difficult. So that would include crowds. It could also include open spaces, which sounds like the opposite of crowds, but that's kind of where that help is unavailable comes in. It's like a fear of being unable to do something, a fear of no one being able to help me, fear of being unable to get out. So, things like that. That's going to be a common one that you might be literally asked, just like, what is agoraphobia? Or they might get a description of what it of the person and their behaviors and like which one is this? So that's the one that you're most likely going to be having a question on. Other ones that are mentioned are social phobia or social anxiety disorder. This is the fear of social situations, being afraid of being judged or scrutinized, um, to the point where you might avoid social interactions, um, or be overthinking past conversations and just hyperanalyzing something and usually taking things uh kind of like if they were against you when the other person might have no like that didn't even cross their mind. They weren't even thinking about that, but in your head, people just don't like you or people are always criticizing you. Um, and usually this leads to like lack of self-esteem and avoidance. And then other types of phobias would just be, this is the definition of specific types of phobias. So excessive fear, high excessive fear of a specific object that is out of proportion to actual danger. So for example, arachnophobia, um, you see a spider and you start screaming and you're just kind of just shaking in the corner, calling for someone to come help you. That would be out of proportion to the actual danger of like a tiny spider, for example. Let's see here. And then this is just like a generalized list of things that help for anxiety. So this is something that you could be putting these for like a select all that apply, for example. So cognitive behavioral therapy, um, desensitization, desensitization therapy. This one specifically, so I'll kind of make exposure and response therapy. So this is OCD treatment. Desensitization is a phobia treatment. Desensitization is also known as exposure therapy. So not to be confused with the other one. So one for phobias or specific anxiety triggers, it's exposure therapy. Slowly over time, the exposure to the fear, so the fear goes away. Exposure and response is specifically OCD because they have a specific response, they have a specific response to that, to what they're being exposed to, other than just fear. They have that ritual. So you're triggering the ritual and then trying to prevent the ritual. So that's exposure and response. While this one, there's the specific response is fear, and then you're just slowly exposing them over time. Like that better. Okay. So expect like a question on this. So someone with a phobia, you're giving them exposure therapy. So I would say expect like something like this to come up as like an answer choice. Other things that help with patient education for anxiety, relaxation, deep breathing, something they call box breathing. Box breathing is essentially the act of breathing in for like 4 seconds, holding it for 4 seconds, breathing out for 4 seconds, and then um, holding off for 4 seconds, and then repeat. So it's just very controlled, very spaced out breathing in order to get their mind off something else and focus just on calming themselves down because sometimes when they're anxious, they get tachypnic and it's just like a way to kind of bring them back out of that anxious thought. Grounding techniques, there's something called the 5 4 3 2 1 method, which is similar to what I talked about. Grounding techniques. So let's see, 5 4 3 2 1. Essentially, it's the idea that you are finding 5 things that you can see, 4 things that you can hear, 3 things that you can touch, 2 things that you can smell, 1 thing that you can taste. The idea is that it's essentially just getting them to focus on something else entirely. And that can also help to de-escalate. oh, That can also help to de-escalate someone as well because you're essentially getting them to focus, just entirely focus on something else, put their emotional brain aside, and focus on their um, focus on their logical brain because you're having them come up with certain things. Um, if someone's really agitated, you could have them like they want like they're like agitated over something specifically. You could try to de-escalate by asking, what would you do? And like what do you think is the like, I want to help you out. But since you're the one bringing it up, I think it'd be worth seeing like what you've thought about what you have thought about as like a solution. Like what should we do about this? And it tries the idea being that you're trying to take them away from the emotions and taking them to the logical side. Um, so that their brain kind of resets as they're thinking about their solutions or they're thinking about just something else entirely. Music, art, support groups, exercise, journaling, diary, all of those can be good answer choices on a select all that apply if you're asked one, like as for techniques for anxiety. Okay, so that was it for the anxiety disorders, and then I'll go into the anxiety pharmacology. Um, For a lot of these, they were gone over in more detail in week 1 or 2, whichever one has depression. I think that's week 1 maybe, or maybe it's week 2. I don't remember. But it's just like a quick review. These are examples of SSRIs. They affect serotonin. They allow more serotonin to stay in the synapses. Serotonin is smiley serotonin, so it helps with mood regulation. Um, Usually they'll end in pram or they'll end in oxetine. There is one exception, which is duloxetine. So the way I like to think of it is kind of like duo. So I think of it like um, it's a double agent. It's not actually an SSRI. Um, it's an SNRI, or you can think of duo as it works on two receptors. It's working on serotonin and norepinephrine as a way to remember that this is the exception. But otherwise, it's going to be pram, oxetine, and then sertraline, which is its own thing. The key thing for SSRIs is going to be the black box warning of increased suicide risk in early treatment. Primarily, though, this is for people that are depressed, because the idea is that the SSRIs in the first 2 or so weeks gives them some of the energy to carry out a suicide plan, and might not be at a point where it actually helps with the thoughts itself or the depression itself, just the physical symptoms. And that's where that black box warning comes from. But you will be asked about this in a test or a quiz or a Kaplan or an NCLEX. So that's important to always keep in mind. Other important ones with SSRIs are sexual dysfunction. So that can include the loss of libido, meaning that you don't want to engage in sexual activities, erectile dysfunction, and also uh, something called anorgasmia, which is exactly what that sounds like, the inability to have an orgasm. And this is usually one of the main reasons why people are non-adherent to SSRIs or they want to switch off their SSRI is for the sexual dysfunction reasons. Other reasons why they people might not be adherent to their medications include weight gain. Certain ones have higher risk of weight gain or increasing appetite. Other things that it can cause that are a little bit less prevalent, especially long term, sleep disturbances. So it might make you feel a little bit sedated, or it might even make you feel you have the inability to fall asleep um, until body gets used to it. So in that short term, people might have like a knee-jerk reaction and not want to take it. So it gets to a point where they're not even letting the medication run its course. But that might be a reason why they might be non-compliant. It can also cause mild bleeding risk because the platelets and serotonin there are platelets and serotonin have a relationship together. You don't need to know the specifics, but retaining um, the way the SSRIs function have an effect not just on the brain, but systemically as well. And serotonin is also involved systemically with platelets. It might cause a decrease in the platelet aggregation, so you might just bleed a little bit longer than you normally would have. SNRIs is affecting your serotonin and your norepinephrine. So this is used when SSRIs are ineffective or only partially effective, or when SSRIs are not tolerated. So in this case, like I said, very often sexual dysfunction will cause people to want to get off, and then they'll consider the SNRIs, which have less risk of that, still there, but less so for the sexual dysfunction. Another reason is that they might just need dual therapy, both serotonin and norepinephrine reuptake inhibition, meaning that your body is shooting out serotonin, shooting out norepinephrine, and this is preventing them from being taken away before they get to do their action. So it's not directly increasing them, but it's just keeping them longer so that they can interact with the receptors. Like we talked about, it can be counterproductive in the immediate because it can lead to increased anxiety, jitters, and insomnia, but the body will adjust after taking the medication for like a week or so, maybe 1 or 2 weeks. And your examples here are going to be venlafaxine. Usually it's extended release, also known as Effexor, and duloxetine, also known as Cymbalta. And duloxetine is, I think on a previous week, Cymbalta was one of your medications to focus on. So on a previous week, there's more information on Cymbalta. It can be used for pain and things like that. Because they are increasing your norepinephrine, or not increasing, sorry, they are having more norepinephrine stay in your synapses. It can also have a systemic effect at higher doses, leading to an increase in blood pressure and heart rate. And some of the same warning signs here. Um, Sexual dysfunction is still there. Okay. For this week, the medication of focus is buspirone. So buspirone is FDA approved specifically for generalized anxiety disorder, preferred due to non-addictive nature, better side effect profile compared to benzos. And this medication is either given as a monotherapy by itself for these considerations, or it can be used alongside SSRIs as an adjunct. So if you are on, let's say you are on Zoloft or Lexapro, you were titrated up to the max dose, you're getting a pretty decent relief of symptoms, but not all the way there for your anxiety. But you're also not having side effects. Instead of just taking you off it and then putting you on a different med, which might go worse for you, they could add buspirone as an additional medication in order to potentiate the effects or just to assist in the therapy of your anxiety. Um, Similar to how either whatever week it was, week 1 or 2, they can add on other medications to SSRIs for depression, such as aripiprazole um, or Caplyta as an adjunct to potentiate the effects. But this one, buspirone would be the same idea, but for specifically anxiety disorder, generalized anxiety disorder. So more than not, it's used as a additive. That's an add-on. But it can also be given by itself if someone has very mild or uncomplicated anxiety disorder, meaning that they don't have depressive symptoms, they don't have panic attacks, generally pretty mild to the point that it's like if we can manage it with just buspirone, we'd rather not introduce the risk of somebody having to deal with the side effects of SSRIs, such as sexual dysfunction. They might say your case is pretty mild, so we're going to start buspirone by itself to not have as much side effects. Something else that SSRIs could do is cause like emotional blunting. So it might make you feel a little bit less in general. But that would be the reason why. Generally, buspirone is going to be more mild. And it's also going to have a slower onset of action. So buspar might take, SSRIs take 2 to 4 weeks to hit their peak, to start hitting like effectiveness, and maybe hit their peak at around 4 weeks. Buspar will take 2 to 4 weeks to get started, and then maybe 4 to 6 weeks to reach their peak. So it's slower than SSRIs, but it's also generally better tolerated than SSRIs. Some of the nursing consideration that's specific for buspirone is that it needs to be taken 2 to 3 times a day, consistently every day, because it has a short half-life. and delayed onset. In general, avoid grapefruit juice with your psych meds. In the case of buspirone, it can increase the levels of buspirone. But in general, you want to avoid grapefruit juice. That could be a question that you get on Kaplan. This medication is only effective as a routine because it needs to build up in the body. It does not work effectively as a PRN. And here are some of the common side effects. The most common ones are nausea and dizziness or lightheadedness that typically go away after your body gets used to it, and especially if it's being titrated properly. And initially, it might cause some drowsiness, but that also goes away pretty fast. So, out of all these key points, the main things here are non-addictive nature, so a good side effect profile, avoiding grapefruit juice, and education on consistent daily use. Um, and yeah, and then additional knowledge is that it's typically used as an adjunct, so in addition to an SSRI, but for very mild cases, it can be given by itself. Some miscellaneous medications in here I have included. Um, the ones that are highlighted are the ones that the focus is on for your pharmacology course, but I've also included the ones that I see at my work often. So gabapentin, which is used for seizures as well, or neuropathic pain, can also be used for anxiety. The reason why is that it indirectly decreases glutamate. So going back to our neurotransmitters, we have glutamate, and we have GABA. GABA is inhibitory, glutamate is exhibitory, so the excitatory. So by decreasing the excitatory, we're having less anxiety spikes. And then this is just for extra information. Like I said, you don't need to know this one as a focus. I just included it because I see it all the time. And then this is something that's like a clinical pro for gabapentin, is that long-term use can lead to cognitive slowing down cognitive brain fogging, memory loss. So I know a few NPs that don't like to give gabapentin for that reason. If they can avoid gabapentin, they'll avoid gabapentin. Another medication that you've probably seen before for other reasons is clonidine. Clonidine, Catapress, Capvase, specifically the ADHD extended release. I talked about it with ADHD, but it also has an effect for physical symptoms of anxiety because it is going to be an alpha 2 agonist, and triggering your alpha 2 receptor is a signal to shut down the sympathetic outflow. So it cancels out your SNS response. So this medication, just like when it's being given for blood pressure, needs to be assessed your blood pressure and heart rate before giving it. And you want to hold it if your blood pressure is under 90 or 100, depending on the parameter, and heart rate under 60. And then some important things is that if you abruptly stop it, it can cause rebound hypertension. And for certain people, it can cause orthostatic hypotension and sedation. Propranolol is a medication to focus on for your pharmacology course. Similar to clonidine, this is going to help with the treatment physical symptoms of anxiety. It is not going to treat your cognitive anxiety. So the worry or rumination on thoughts and things going on, that's not going to go away, but it is going to help with the physical symptoms. So this is best used for performance or situational anxiety. such as stage fright or public speaking. So this is for somebody that is having anxiety over something maybe a little bit more logical. So something that is going to be anxiety causing, but where their anxiety response is overblown or is like over exaggerated anxiety response by their body. So, um, so their body is just overreacting to the anxiety causing trigger, and their main issue is the physical symptoms. This is a beta 1 and beta 2 antagonist. Um, so this is shutting off the SNS directly. And similar to clonidine, you're going to have to assess the blood pressure and heart rate prior because it is also a beta 2 um, antagonist. It does affect the lungs as well. So this is a medication to be used with caution in patients with asthma or COPD, and also diabetes because it can mask it can mask the symptoms of hypoglycemia. Let me see. Uh, Because this is a medication that affects your blood pressure and heart rate, you're also assessing for bradycardia, hypotension, fatigue after giving it, similar to clonidine, possible orthostatic hypotension. So when they get up quickly, they could have a fall. And same thing, if you abruptly stop it, typically this can be given routine two to three times a day, or it can be as needed. But if this is a routine and it's abruptly stopped, it can cause rebound hypertension or rebound tachycardia. Okay, so the main things for focusing on propranolol is all of these considerations here because it is a beta 1 and beta 2 antagonist, and the idea that it only helps with the physical symptoms of anxiety. Oops. Another medication that I see a lot is hydroxyzine. This is an antihistamine. It will not cause dependence or withdrawal. This is a same class as a Benadryl, and it is primarily used as a PRN, if possible, short term, because long term use can lead to anticholinergic side effects. And like I've mentioned in the past, if you're in doubt, most of your psych meds cause anticholinergic side effects. A lot of antipsychotics cause them. Um, some of these other medications down here are going to cause them. So when in doubt, it's usually the case that they're going to cause anticholinergic side effects. And this is especially worth considering with older adults because they have a higher risk of falls. And when they have a fall, they could break their hip, which can lead to a like 66% mortality rate due to long-term complications. So these are the side effects that you're potentially going to see for long-term use. Um, Sedation, cognitive slowing, confusion, constipation, urinary retention, dry mouth as well. Solpadem or Ambien is another med that was listed down as a prototype medication for focus. This medication is not given for anxiety. It's more of a sleeping medication, or it is a sleeping medication. But it can have similar effects, but it's more of like it's a bedtime drug. It is not a benzodiazepine. It is not a barbiturate. It is a sedative hypnotic that assists with insomnia. So if you're asked questions on Ambien, the key facts, the key things here are going to be your side effects and consideration. This medication should only be taken immediately before bed. So if somebody does not have the ability to stay in bed to sleep for 7 to 8 hours, they should not take it. it can cause daytime drowsiness and next day impairment, kind of like a hangover-like effect, which can cause falls in elderly adults, and should not be given just because it is a sedative, sedating medication, SNS sedating, depressing medication. Should not be taken with alcohol, benzos, or opioids, or has to be done with caution. Uh, Ambien can cause amnesia, like loss, forgetting, um, just forgetfulness. It can cause dependence. It can be addicting. And the most thing you'll see a lot in questions would be that it can cause some interesting sleep behaviors, such as sleepwalking, sleep driving, sleep eating, which is crazy. So people get into like a state where they're like half asleep, half awake, but they're able to do certain things like this, as well as some typical side effects like headache, dizziness, and nausea. So in your terms of your pharmacology testing, definitely read up on this stuff here. Um, be familiar with some of the complex sleep behaviors that it can cause. The next one is your phenobarbital. This is a barbiturate. This is not used anymore for anxiety disorders. It is primarily used for seizure disorders or severe alcohol withdrawal, but it's less used because being a prototype medication, there's better things around now. When it comes to questions about phenobarbital, the main things to consider is that it has a very long half-life. So that has a risk of accumulating in the body, especially for elder adults. And this comes with the high risk of dependence, cognitive impairment. It's a CNS depressant, so you're worried about um, you're worried about respiratory depression, sedation, and because it can be habit forming withdrawals or even overdosing, especially because of that risk of accumulation. So that's your key things here is look about the things that it can cause, the things that it cause it to be high risk, and the fact that it has a very long half-life. Last class of medications are benzodiazepines. Also, these are CNS depressants. They have a high risk of abuse. It is not the first line for anxiety and only really given in cases where it is very severe and requires additional medications where the SSRIs, the Buspar, if it's GAD, um, none of that stuff, the therapy isn't working because they're CNS depressants. They are have the same high risk as your phenobarbital, so you get to kind of group them together in that sense. And again, the caution is with elderly patients because of the risk of falling. The thing I would keep in mind, because Ativan is one of your prototype meds to focus on the um, for your farm, definitely keep in mind the withdrawal symptoms of it. So these are medications that are given also for seizure disorders, like in the case of like a status epilepticus, barbiturates and benzos are used for that. So if somebody is having a withdrawal of it, and this no normally helps to prevent seizures or manage seizures. If they're withdrawing on it, they have an increased risk of seizures. They have risk of anxiety rebound, tremoring, irritability, insomnia. So that's something to keep in mind um, with the Ativan. For your examples, I wrote down the most common benzodiazepines, but your focus is still on Ativan. But in the scenario where you want to learn a bit more about it, I wrote down their indications, the way they function. So some of them function faster and last less, like Xanax. So we mentioned that this is for panic attacks. So it works because it's fast and it only lasts a short amount of time. So it lasts the panic attack duration, helps manage that, and then you're kind of off off on your own. The Ativan is there for acute agitation, acute anxiety, or status epilepticus, which is the seizure disorder, multiple seizures back to back, or seizure that lasts longer than 5 minutes. This is fast onset, intermediate duration. And the reason that Ativan is used so often, it's kind of like your drug of choice for inpatient, for all that stuff, is because it, when the body metabolizes it, the metabolites, the things that the Ativan is broken down into by your liver, is inactive, meaning that it has no effect. So the way Ativan runs its course in the body is more predictable, and there is less drug accumulation, making it safer for people with liver problems or older adults. And listed here are other ones that are also benzodiazepines in scenario where you get tested on benzodiazepines specifically. Clonopin or clonazepam we talked about for chronic anxiety or maintenance of panic attacks. Like I mentioned, if your panic attacks are not being properly managed by your SSRIs, they can throw in some benzos because that reaches the criteria for it. Clonazepam or Klonopin as slow to moderate and has a long duration due to having a long half-life. So it stays in the body for longer in order to manage your anxiety for longer periods of time. Prophylactically helps with panic disorder. Chlorodiazepoxide or Librium is modern use is alcohol withdrawal. It used to be for chronic anxiety, but nowadays it is just not considered worthwhile for anxiety. It's just less predictable than like a Klonopin, for example, because um, while it also lasts a long time in the body, which is why it was used for chronic anxiety, when your liver breaks it down, it has active metabolites, meaning that with similar effects, meaning that your liver breaks down the Librium, and then the thing it breaks it down to also has a similar SNS depressing effect. So it's less predictable. Um, and it might depend person to person how well their liver breaks it down on how that effect is going to last, how much it's going to accumulate. So for that reason, it is not used for chronic anxiety anymore. But that might be helpful for someone with alcohol withdrawal because this person needs a lot of prophylactic assistance to prevent their symptoms and risk of seizures and things like that. Diazepam or Valium, primary indication seizures or very, very severe acute anxiety. This has a very fast onset and lasts a very long time. Same reason as the Librium, it has active metabolites with similar effects. So your body breaks it down. Usually when you break things down, it's to inactivate them, but the Valium and the Librium, the things that's breaking down into, are active with similar effects. Benzodiazepines do have a reversing agent, just like Narcan is for opioids. Flunazanil or Romazicon. The thing to keep in mind with Romazicon is that it can precipitate seizures in chronic benzo users. So somebody that is chronically that has to be used in caution with has to be used with caution because somebody that is chronically using benzos, they're giving uh, the reversing agent, and then they're having like acute sudden kind of like acute sudden withdrawal almost because their body's now missing the thing that it's used to. So it increases their risk of seizures. Any questions on the pharmacology aspect or any medication or have a question on treatment um, for your pharm class. Otherwise, I have the rest on personality and eating disorders. I'll try to get through really, really quickly. Yeah, because I don't have as much time today, but it's also not a massive, massive focus, at least not on specifics. Okie dokie. So personality disorders, the key things with personality disorders are knowing that treatment is going to primarily be psychotherapy. You can't medicate a personality disorder. You can only treat the accompanying symptoms. So if they have depression, anxiety, or mood instability due to their personality disorder, you can treat that, but you can't treat the personality disorder itself with medications. It requires therapy. And one of the key things for personality disorders, primarily, is that you'll be tested on cluster B types. I have ways for you to kind of remember them, but you don't have to like hardcore memorize each individual one. You're going to be primarily tested on cluster B more than anything. So cluster B, I have again my way for remembering them. Cluster A is for awkward, so paranoid personality, mistrust of others, schizoid personality, detached, poor social skills. Cluster B, B is for B. Uh, Dramatic, emotional, erratic. The examples that you'll be tested on: antisocial personality disorder, more common in men, people that lack empathy or remorse, belief that rules do not apply to them. They have little regard for anybody's feelings or the rules, and they can be impulsive, deceitful, and rule breaking. These people are higher risk for aggression, violence, or criminal behavior. It's kind of thought of it. Antisocial personality disorder. A lot of the, I think it's like a lot of the people that are serial killers happen to be antisocial, have antisocial personality disorder. Um, and a lot of them can be really good at masking empathy or masking uh, with people for personal gain. And then when it comes to the treatment for that, it's going to be a lot of setting firm limits and not letting them get away with things for your question. So you're going to have a question maybe where like the patient's acting out, and it's going to be important that you respond with firm boundaries. Like that is not okay. You can't do that. Like, yeah, it's not something that's safe. You shouldn't do that. Setting firm boundaries is going to be your key thing with the personality disorders. Borderline personality disorder, more common in women. A lot of the times it's a comorbid, people with borderline had a history of being sexually abused. The key things with it is emotional instability, fear of abandonment, and a lot of their behaviors can be interpreted as manipulative because they have inappropriate coping skills and uh, fear of abandonment, which leads to a heightened sense of emotions and attachment. So when you see in media, like usually media portrays bipolar as kind of flipping from 0 to 100, but bipolar people are have manic and depressive episodes that are like more long lasting, they're longer term, as opposed to like a sudden flip back and forth. So usually when you think of a bipolar person in like TV or movies, they're actually that's more attributable to a borderline personality disorder than anything. So borderline personality are the ones that kind of go from 0 to 100. They can suddenly flip just like that because they have a heightened sense of emotions and attachment, meaning that they usually either see you as completely good or completely bad. So you're either the best person ever or you're the worst person ever, and that switch can flip immediately. So any boundary setting or any pushback that they get, they can see that as feeling betrayed. Like they feel genuinely betrayed and hurt to an extreme amount, which causes them to lash out or um, do certain things like, oh, I'm going to kill myself now because you said that to me. And the idea with patients with borderline is that the appropriate response is to be firm and consistent and not to take it personally one way or the other. So when they're complimenting you and telling you you're the best nurse ever, whatever, like you're the best, you're my favorite, don't take that personally. And then don't also take it personally when they tell you all of a sudden that you hate them and you suck and you're the worst person ever and blah, blah, blah. And then that kind of 0 to 100 is called splitting, rapidly switching between seeing people as either completely good or completely bad. They have a hard time being able to see two sides of one person at the same time. So they don't see you as like a balance of you're this person that's super helpful and super caring, but sometimes you get frustrated or sometimes you're busy and don't have time to do things, but they either see you as one or the other. And they might lash out at you, and then the next day they're loving you again. So it's just about firm and being firm and consistent and not taking things personally. So that's the focus on here. So expect the question on borderline personality disorder to be basically that. They're looking for you to pick the answer choice that is being firm, consistent, setting boundaries, and not taking things personally, um, as well as just monitoring or assessing for self-harming behaviors because they are at higher risk of committing self-harm, usually for attention, more than anything. So slitting their wrist, for example. While antisocial personality disorder, you still have to be firm and consistent with them, but you're looking out more for um, violent behaviors or aggressive behaviors towards other people. And then the other ones that are tested less so are histrionic and narcissistic. Histrionic basically is like attention seeking for attention, self-esteem, approval. Narcissistic is self-centered, manipulative for self-gain or status, as opposed to antisocial personality disorder, which is just impulsive, rule breaking. Um, and you can read up more here if you want, but it's not really the focus. Cluster C, I have C for lack of confidence, avoidant personality disorder, dependence, codependence, for example, somebody that excessively relies on someone else, and also obsessive compulsive personality disorder, which is not to be confused with ob- obsessive compulsive disorder. This is just the name of the personality disorder. This is just somebody that is focused on rules, perfectionism, very serious and formal, but they don't have obsessions and compulsions in the way that someone with actual OCD does. Um, these are the goals overall, but like I mentioned, therapy, firm boundary setting, redirection. That's going to be your goal. For the eating disorders, you have anorexia nervosa, comes with negative body image. It can include restrictive dieting, excessive exercising, body dysmorphia. And the things for you to focus on for your testing here would be some of the physical demerits of it. So changes in your vital signs because they're emaciated, they're going to be underweight, they're going to have decreased heart rate, blood pressure, maybe even temperature. And those are some of the things where then it's like, okay, now they need medical assistance potentially. And then here's some other things that kind of go with it. lack of periods for women because lack of resources. Um, they're going to be more cold due to lack of body fat. The body might try to compensate by making thin hair. They'll have dry skin, brittle hair, brittle nails due to lack of nutrients. Um, and they overall might have an obsession with food, even though, like, they are restricting, but they might be hoarding or concealing food. Uh, so maybe it could be like you give them food and then they hoard it or hide it so that, and then you're like, yeah, I ate all my food, but they're actually like hiding it. Um, maybe they're watching mukbangs, or something like that. Criteria for hospitalization. This is some of the things that make sense, right? Just having changes in their vital signs that are below what would be expected of someone that doesn't have a medical condition. Maybe they're anemic. Probably they have electrolyte imbalances because they're not eating, which can then lead to possibly arrhythmias, or they could be suicidal because of their body dysmorphia, or their body weight is considerably less than what it should be for their height and gender. The next one is bulimia, which is essentially binge eating followed by vomiting or laxatives, excessive exercising, but usually like the hallmark is vomiting after, which is why the key focus for bulimia is assessing for mouth sores, decay of teeth, and maybe even inflammation of their throat, which is definitely very, very bad because that can lead to esophageal scarring, which could lead to blocking their airway or increased risk of cancer, esophageal cancer. And then mouth sores that could lead to some like infections in their mouth, things like that. The criteria for hospitalization is going to be relatively the same. Their manifestations are also going to be similar. They're going to have risk of electrolyte imbalances. They might have acid-base imbalance because they're vomiting. They're getting rid of so much acid. And then other key things, their weight is fluctuating because they do eat, but then they vomit it. They'll vomit it out, but their body still absorbs a large amount of the nutrients. So even though they binge eat, it kind of almost balances itself out. They're not overly skinny, they're not overly overweight. Um, Something that could be seen in literature, Russell sign. This is callousing of the knuckles, specifically when they're trying to induce vomiting. So if you see that, that's what that refers to, but I don't expect too much testing on eating disorders on your quiz itself. Maybe on Kaplan, I expected to see a little bit more. But your criteria for hospitalization is going to be similar to the anemia, focusing on arrhythmias, electrolyte imbalances, dehydration, and vital sign changes. And this is the Russell sign. It's showing the calluses on the knuckles. Binge eating is suddenly just eating a lot, and usually caused by emotional distress. People will be overweight, frequently eating in secrecy. Um, they can be feel guilty or depressed after binging. But that's pretty much it. The focus, if you are going to be tested primarily on, or going to be tested on eating disorders, the focus is usually on anorexia and bulimia. Um, Especially because they come with malnutrition, which then leads to other medical things to kind of look out for. Your general goals is safety for people that have like suicide risk associated with their appearance and whatnot. ABCs always going to be your issue. So like if they're having hypotension, For example, that's going to be part of your ABCs. Um, and proper nutrition. So people might need supplementation, multivitamins. I don't expect you to be tested on it, but something that's important with people that starve themselves is refeeding syndrome. So if somebody has not been eating much at all, been starving themselves, very malnutrition, they have to be very careful with restarting eating because their body is gonna de- detect the food and in response just have a massive surge of insulin, which we know can cause shifts in electrolytes. So your phosphate, potassium, magnesium will then shift into the cells, which causes electrolyte imbalance, which can lead to not heart attack, cardiac arrest, fatal arrhythmias, heart failure, seizures, respiratory failure. So if you get a question on refeeding syndrome, for your Kaplan, more than likely, if you see it, it's on Kaplan. That is what that's referring to. Okay. Any questions on anything here? If not, I'll just post the stuff and then send you guys on your way so that I can um get ready for work because I have work in like 30 minutes. Well, not 30 minutes, but I leave in 30 minutes.